Hello and welcome. I'm Mary Pavlou, and as president of Fabry, the national network, I'm delighted to invite you to our Fabry Moment webinar series for patients living with Fabry disease. This collaborative initiative between FIN and Sanofi aims to empower your knowledge about disease monitoring and building your care. This is our second webinar where we are talking about building your care. Our disclaimer, of course, for our faculty is this program is being sponsored by Sanofi. The speakers are being compensated or receive a honorarium from Sanofi in connection to this presentation. The content is jointly developed by FIN and Sanofi, and there is no provide of any medical advice, diagnosis, or treatment. Any content and any health information in this webinar is for general educational purposes only. If you have any further questions, you can talk and ask questions to your healthcare professional about anything that concerns your health. And on my personal disclosures, I work with Sanofi, Amicus, Chiesi, and Takeda on several projects, always for educational and awareness purposes on behalf of FIN, and all fees go directly to FIN. And I'm delighted to introduce you with a second webinar, Building Your Care Matters. We will start with Professor Alberto Ortiz. He will get us through the protective strategy for our kidneys, and we continue with Professor Maurizio Peroni. He will talk about protections about the heart, and continue with Professor Juan Polite. He will talk about pain and GI problems, symptoms, how to manage those as a neurologist, and we'll finalize this webinar with Dr. Nadia Ali. She's a psychologist, and she will talk a little bit about our mental well-being and how important this is.
Thank you, Mary, for the kind introduction. And let's now focus on how to protect our kidneys, kidney protective strategy. I have to make some disclosures because of my relationship with pharma companies, specifically with Sanofi and Chiesi. And then let's focus on how to protect our kidneys. But on top of that, we know that once kidneys are damaged, the kidney disease tends to progress even if we address the original cause. And we know this, for example, for diabetes and diabetes nephropathy. So in diabetes, we treat diabetes and we also protect the kidneys, and we should also think about doing that. You should also talk about how to do that with your physicians. And what we can do. So first step, we all can do, we all should do, we should all be doing, even if we have no disease at all, which is lifestyle modification, healthy lifestyle, healthy diet. And in case of kidney disease, this means avoid excess protein, excess salt, excess phosphate, as for example in cola drinks, and adapt dietary potassium intake if you need it. Then we should all engage in moderate physical activity so as to keep our weight in a target range that avoids both overweight and obesity, limit alcohol consumption, and of course, quit smoking as soon as possible if you are still smoking. Then discuss your physician how to delay kidney progression and protect your cardiovascular system with medication on top of whatever therapy you are taking for Fabry. So the aim of these interventions is to decrease glomerular hyperfiltration. So the excess work by the kidney filters, which are called glomeruli, when some of these filters are already not working. So the healthy ones have to do their work and the work from the glomerulus that have already died. So discuss with your physician how to decrease glomerular filtration and decrease albuminuria, that is the loss of plasma proteins, of blood proteins in urine. These medications may also reduce fibrosis, that is scarring, and inflammation in the kidneys, and preserve key kidney functions such as the production of the anti-aging protein clotho, and also improve blood pressure control. And then you should discuss with your physician how to manage CKD complications. So first, how to monitor whether they are there, and if they are there, how to treat them. So as to decrease cardiovascular disease risk, treat anemia, which is a consequence of chronic kidney disease, maintain the health of your bones because they become unhealthy because of chronic kidney disease, and treat high blood acidity if this has been one of the consequences of chronic kidney disease in any specific person. Finally, if the kidneys fails, if they can no longer provide their function, if kidney failure develops, we should replace kidney function by either dialysis or ideally kidney transplantation. Okay, so these are the treatment goals in Fabry nephropathy. First, stabilize glomerular filtration, that is the kidney function of filtering the blood to eliminate toxins, or at least slow the loss of the glomerular filtration function of the kidneys. And we also aim to reduce albuminuria, to reduce the loss of blood proteins in the urine, or if it's very high, at least to stop it from getting worse. So mild albuminuria is called A2 albuminuria. This is likely reversible in Fabry. If it gets more severe, what we call A3 albuminuria, this is usually not reversible. If instead of albuminuria in urine, we are talking about proteinuria, that is protein in urine, if this goes up, it is likely at the A3 stage of albuminuria. So proteins from the blood are getting lost in the urine because the glomerular filter is damaged and it is no longer retaining blood proteins in the blood. Okay, so we have the therapeutic goals according to the kidney function, which we measure with a variable that is called the estimated glomerular filtration rate, eGFR. So if GFR is normal and there is no evidence of kidney injury, so if albuminuria is also normal, this means kidney health, and the aim should be to maintain kidney health. Then we may have still normal kidney function, so glomerular filtration rate above 90. More or less the number of the glomerular filtration rate is the percentage of kidney function remaining. So above 90 is more or less 100%. So if kidney function is normal, we aim to maintain normal kidney function. If kidney function is already decreased, or there is already evidence of kidney injury because of albuminuria over 30 milligrams per gram, the aim would be to stabilize kidney function. So kidney function, once lost, cannot be recovered. But therapy aims at stabilizing it where it is or slow its progression. If kidney function is really low, below 60 mL per min, we call this chronic kidney disease. Therapy can slow or delay the progression to kidney failure. We should try at this stage, talk to your physicians about how to detect, identify, and eventually treat if there are present complications such as anemia, bone health, nutrition, or acidosis, so the presence of acid in the blood, and prevent cardiovascular disease, which is a consequence of chronic kidney disease. Eventually, if kidney failure develops, if kidneys are no longer able to provide their function, you should discuss with your physician about how to prepare for and provide optimal renal, that is kidney replacement therapy, by dialysis of, if available, kidney transplantation. Okay, so we talked about kidney function, and now we are talking about kidney injury. Kidney injury, we know there is kidney injury when albuminuria goes up. So when blood proteins, specifically albumin, which is a blood protein, is lost into urine. So we talk about no kidney involvement, kidney health, when kidney function is normal, eGFR above 90, and albuminuria is below 30. And albuminuria is below 30, so we want to maintain albuminuria below 30. When albuminuria is slightly increased, what we call A2 albuminuria, we want to normalize albuminuria or at least stop it from getting worse. When albuminuria is severe, over 300 milligrams per gram, what we call A3 albuminuria, we want to reduce its levels below 300 milligrams per gram and prevent CKD-associated cardiovascular disease. So what are the basics of kidney protection? This guy is important. What we are seeing here, this yellow smiling cell, is the glomerular podocyte, the cell that prevents albumin and other blood proteins from leaking into urine. So we should protect this guy because we cannot replace it. It's a terminally differentiated cells like neurons that we cannot replace if they are lost. And they may get lost if kidneys are injured. And this is how it works. So what we are seeing here is the glomerulus, the kidney filter. And the glomerulus filters blood because blood is at a higher pressure inside than outside the blood vessels. So this pushes the water within the blood outside to form urine. But the podocyte is sitting outside the glomerular capillaries, outside the vessels, trying to attach to the vessel wall. And they have these prolongations, these feet, this is podocytes, small feet type cells, and they try to attach to the vessel wall, which has water jets, that is the glomerular filtration, the blood being filtered. Okay, whenever we have less glomeruli, the remaining glomeruli, they increase the pressure, the filtration pressure, so as to try to compensate for the loss of other glomeruli. But this overworks these glomeruli that are hyperfiltrating. The water jets are stronger, and they may push into the urine the glomerular podocytes that are outside the capillaries and are injured. You see, these glomerular capillaries, they no longer have this feet. They may be pushed into urine. This is called podocyturia. Podocytes are lost, and eventually glomeruli are lost. So podocytes are pushed into urine when there is excess glomerular filtration, excess work of the kidneys, and also as more blood is filtered, the kidney tubules that reabsorb part of the filtration, so the kidneys filter like 180 liters per day, but we only pee 2 liters. So all the 178 liters are reabsorbed by the kidney tubules. If there is glomerular filtration, hyperfiltration, they overwork. So the kidney protective drugs decrease hyperfiltration, protect the podocytes, and decrease the workload of the tools. And kidneys that work at a slower rate, they may keep working for more years. Okay, so this is how they do it. Drugs that decrease hyperfiltration either open the exit or they close a little bit the tap so as the pressure, the blood pressure within glomeruli is not so high and there is not so much hyperfiltration, strong water jets that push podocytes into the urine. Okay, so we need a holistic approach to kidney protection. On top of Fabry specific therapy, you should talk with your physician about whether you need specific kidney protection and cardiovascular protection. That means something that is you can do by yourself, lifestyle modification and diet, and something that you should consult with your physician on how to prescribe it if needed. This is kidney protective therapy. And if there are complications from the kidney disease, such as heart complications, anemia, blood acidity, loss of red blood cells, bone strength issues, or even total loss of kidney function, you should discuss with your physician how to protect your heart, your blood counts, treat the acidity, keep the bone strength, and eventually replace kidney function. So thank you very much for your attention.
Thank you, Mary, for the nice introduction. And In this talk, we will discuss how to manage the cardiovascular symptoms and how should be the follow-up of patients affected by Fabry disease. These are my disclosures. As a cardiologist, I have to say that we have a very central role in the management of patients with Fabry disease because cardiovascular involvement is a main driver of prognosis, is a main cause of mortality, and also a main cause of symptoms that may affect the quality of life of patients with Fabry disease. As you can see in this cartoon, at the very center of the cardiological team, we have the cardiomyopathy specialist because Fabry disease indeed causes a cardiomyopathy. But together with him or with her, we have many other specialties that can contribute to manage the cardiovascular involvement in Fabry disease. For example, cardiac surgeon, electrophysiology specialist, imaging expert, and so on. This is very important to manage all the possible complications of Fabry disease affecting the heart. As we know, Fabry disease is a disorder caused by the enzymatic deficiency of a lysosomal enzyme. So all the Fabry disease specific treatments are aimed to restore or to increase enzyme activity. We have enzyme replacement therapy based on administration of the enzyme from the outside. We have chaperone treatments able to improve and increase the enzymatic activity in some specific disease genetic variants. In addition to Fabry disease specific therapies, we have always to consider conventional organ specific therapies that are as important as Fabry disease treatment because they contribute to manage the organ-specific complications. Whenever we start a treatment, we have to set the therapeutic goals and we have to have very clear in mind that the goals are based on the baseline evaluation, on the starting point. For instance, if we have a patient with no hypertrophy, our therapeutic goals will be to prevent the development of hypertrophy. But if we have, when we start treatment, some degree of left ventricular hypertrophy, the therapeutic goal will be to prevent the progression of the hypertrophy and to stabilize the cardiovascular stage. Similarly for fibrosis, no fibrosis, the goal is to prevent fibrosis, and so on. This is true also for arrhythmias. One of the main goals of treatment, also of organ-specific therapies, is to prevent sudden cardiac death and major arrhythmias, to prevent stroke and the other complication of atrial fibrillation, and to treat bradycardia when the heart is beating very slow and maybe we need some support, for instance, with a pacemaker. Heart failure is another complication of Fabry disease, and we may have heart failure even when the function of the heart is still normal, but the heart is not able to feel normally. So we have some drugs, we have some possible interventions that may reduce the burden of heart failure, reduce the hospitalization, improve the tolerance to exercise, and to prevent the progression of the symptoms. Also consider that some patients with Fabry disease may be exposed to conventional risk factors like dyslipidemia, hypertension, smoking. It is very important to reduce the burden of the conventional cardiovascular risk factors. So treating hypertension and dyslipidemia, stop active smoking, and so on. These are very important part of the management of Fabry patients. When we consider the patient with Fabry disease and cardiomyopathy, as well highlighted in this picture, together with the diagnosis of cardiac involvement, as soon as we have a diagnosis, we have to start the follow-up and we have to assess and manage all the complications that may derive from the cardiac involvement. And so it is very important to have a follow-up of the patients with a very fixed schedule, including ECG, echocardiography, Holter, and other tools that, according to your cardiologist, are necessary to evaluate new symptoms or to evaluate disease progression. It is also important to know that even if the patient has Fabry disease, all the cardiac interventions are allowed. There is no contraindications to have cardiac surgery or other cardiovascular interventional treatments that can be necessary. So Fabry disease is not a contraindication to all the standard cardiological procedures that may be needed to treat complications. If you have atrial fibrillation, there are some specific features of Fabry disease that may suggest to use some drugs instead of others. For instance, direct oral anticoagulants are to be preferred to vitamin K antagonists because the latter may have some kind of renal damage after prolonged administration. And also the risk of hemorrhagic complications is lower with direct oral anticoagulants. Atrial fibrillation is a well-known complication of Fabry disease, so it is very important to detect atrial fibrillation when it's present. So we can consider your cardiologist, you should consider prolonged ECG monitoring with prolonged Holter monitoring or even with some implantable devices. And in some patients, there is experience also with interventional procedures like ablation to treat atrial fibrillation. There are some caveats in Fabry disease, and for instance, we should not use the conventional tools or risk calculators to estimate the risk of stroke because Fabry disease has an increased risk of stroke. And so you should not use the scores that we use for patients without Fabry disease. And also for some drugs like amiodarone, there are some studies suggesting an interference of amiodarone with some treatment like enzyme replacement therapy. So before using amiodarone, you should consult your cardiologist and your physician treating you for Fabry disease before prescribing this drug. Similarly, Fabry disease may have some ischemic heart disease complications, and these are mostly related to the small coronary vessels. So you may have chest pain or even some small myocardial infarction with normal coronary arteries. And the reason is that in Fabry disease, you may have a damage of the very small vessel inside the myocardium. And this is particularly common in patients with left ventricular hypertrophy. So remember that if you have chest pain, you have to consult your cardiologist, your physician, and consider the possibility that you may experience some very small myocardial infarction due to Fabry disease. Fabry disease may also affect the valve, and this is an example of a mitral valve disease in a patient with Fabry disease that you see here the blood, the red blood going in the wrong direction, and here after treatment with an interventional cardiology treatment that is called mitral clip, where from the vein of the leg, we can put a clip between the leaflet of the mitral valve to reduce the regurgitation. You see here that the blood going in the wrong direction is very small now after the intervention. This is to say that may benefit from all the technical possibilities that today we have in cardiology. Similarly, when the hypertrophy is so huge to reduce the exit of the blood from the heart to the whole body, to the aorta and all the other arteries, this can be managed in different ways. We have drugs, we have surgery, and we have interventional procedures that may reduce the hypertrophy and improve the outflow of the blood from the left ventricle. For the prevention of sudden cardiac death in Fabry cardiomyopathy, we cannot use the calculator that we use for other types of cardiomyopathies similar to Fabry cardiomyopathy. For instance, sarcomeric hypertrophic cardiomyopathy. We have a calculator to calculate the risk of sudden death in this cardiomyopathy. But this has been developed for this cardiomyopathy and cannot be used for Fabry disease. So when we have a patient with an hypertrophic cardiomyopathy caused by Fabry disease, we have to consider other factors that you see listed in the screen: severe hypertrophy, extensive fibrosis, arrhythmias at the Holter monitoring, and also modifications of the electrocardiogram that may suggest some problems with the conduction system, the electrical system of the heart. So again, you can understand that monitoring and follow-up are very important. It's important to have Holter, it's important to repeat cardiac magnetic resonance whenever your physician suggests to repeat CMR, and to monitor the ECG and the echocardiogram. This is important because when we have more of these risk factors, your cardiologist should consider or can consider to put an ICD to prevent lethal arrhythmias. Is also progressive in the heart. We have an early stage that can be detected by modern cardiac magnetic resonance scans, including T1 mapping. Then we have a stage when the disease progresses with inflammation and more storage, and a later stage with extensive fibrosis and advanced damage. So the follow-up and the imaging are important to monitor the progression of the disease and also to make a diagnosis very early. So it is quite clear that the management of patients with Fabry disease and cardiac symptoms is very complex and is an holistic approach, because we have the Fabry-specific therapies, the conventional therapies, the lifestyle modifications that are recommended for all patients, for all people, not just for Fabry patients, also the management of cardiac complications. It is important to keep in mind that if you have Fabry disease, you have no contraindications to any of the possible cardiac interventional treatments that we have today, including angioplasty, pacemaker, and whatever. Fabry disease is not a contraindication to treat these cardiac complications. So, as a patient, it is important to remember, if you have heart involvement or if you are at risk of having cardiac involvement, remember that you may have an increased risk of arrhythmias, you may experience some chest pain, and also small myocardial infarction with normal coronary arteries, and you may have atrial fibrillation. So it is always important to discuss symptoms, particularly new symptoms, with your physician that will guide you to the best available treatment for any of these cardiac complications. In conclusion, the cardiac involvement in Fabry disease requires a very holistic and complex approach by a multidisciplinary team. From the patient perspective, it is very important to follow the treatment, either Fabry specific or organ specific, to manage all the possible complications and to prevent all possible disease progression through exercise, taking care of what you eat, taking care of your mental health, and also having a good social relationship. So the management is complex and requires really a multidisciplinary approach from the physicians, but also a good approach from the patient side. Thank you.
So thank you very much again for the invitation. Thank you to Mary Pablo from FIN. Thank you for Sanofi for this opportunity to talk about some practical aspect related with what we call neuropathic pain and the gastrointestinal manifestations in our patient with Fabry disease. So you have here my disclosures, and When we talk about neuropathic pain, maybe it's very important that you understand that it's not just that pain in hands and feet. No, it's more complicated. We have different type of neuropathic pain or different way to manifest this discomfort. There are different classifications, but we are still using the old one. We say that it's very common the presence of the acroparesthesias, this tingling, nagging sensation in hands and feet, very common, very early, mainly in the classic phenotypes, but it's a very, very common situation. But the real disabling, complicated situation are what we call the pain crisis. It's a severe pain. And it's not just localized in hands and feet, also in arms, in the leg, in the abdomen, in the chest. So it's a severe pain and it's very common to spread to different areas of the body. And the another important point is that these pain crashes are triggered by the presence of, for example, fever, exercise, when you have a change in the temperature outside or the inner temperature. This is why I mentioned fever. When we move to the right part of the slide, you will see the classic manifestations related to the gastrointestinal involvement. After meals, abdominal pain and cramps. Then, many frequent episodes of diarrhea. This is the common situation. But in some patients, after the age of 30, patients out of treatment, they may have severe complications. For example, what we call the diverticular perforation or the pseudo-obstruction. And this is a different type of abdominal pain. And you have to talk with your physician when you feel another type of abdominal pain. So, my dear physician, now I'm having other different type of abdominal pain. So then, what is the reason for this? Well, if we talk about this pain in hands and feet, we know that the deposition of the GB3, you know the GB3. The GB3 is the fatty acid with sugars, which is the substrate, what you cannot remove because the absence of the alpha galactosidase A end up in this deposition. And this fatty acid is deposited in a specific part of our cables, our peripheral nerves, our sensory peripheral nerves. This is the dorsal root ganglion. But if you try to explain the mechanism of abdominal pain or diarrhea, it's almost the same, but in some specific ganglia in the intestine. And this is part of what we call the autonomic nervous system. Okay? So you can see here some pictures. And these blue, these blue circles are the expression of the deposition of these fatty acids. So we mentioned the symptoms, we mentioned the mechanisms, but now let's talk about the diagnosis, the assessment, and also the follow-up. When we talk again about neuropathic pain, in some countries we have the possibility to do a specific electrophysiological test. It's what we call the quantitative sensory testing. We apply different temperatures in hands and feet, and the patient should distinguish the increase or the decrease in the temperature. And this is talking to us about the functioning of some specific cables, peripheral nerves. Also, in some places, and I gotta say it's more academic, it's not a routinary exam, you may receive the order for a skin biopsy. And in the skin, you can quantify the pain receptors. But again, it's not common, it's super exceptional. It's useful, yes, it's useful, but exceptional. And then we have the simple questionnaires, scale, surveys. And today it's important because we have many specific surveys for Fabry disease, for pain in hands and feet. But if you see in the right part, when we talk about the diagnosis of gastrointestinal compromise, you have images, echography, tomography, magnetic resonance. But in some patients, we request the endoscopy, upper or lower, not just thinking in Fabry compromise. because we have to rule out other things, other disorders like gastritis, like diverticulosis, like celiakia, or many others. But again, you can see in the bottom part, in the right part again, a specific questionnaire for gastrointestinal manifestation. We have to follow this manifestation. We need a baseline. When you just receive your diagnosis, before you start on a specific or non-specific treatment, and then the monitoring is done using this scale. Why I insist with pain and gastrointestinal symptoms? Because if you follow the same guideline that we follow, the physicians working with patients with Fabry disease, you will see that these early symptoms, again, abdominal pain, diarrhea, neuropathic pain, are enough criteria for the prescription of a specific treatment. You can see in the left part the guidelines for children with Fabry disease coming from the US, and then another guideline, and part of these old guideline for adult patients with Fabry disease. And we said, if you have a patient with symptoms related with Fabry disease, like these symptoms, you have to start the treatment. Okay, this is so important. But when we talk about pain, you have to keep in mind that there are different types of pain, and pain is super common in general population. And today we are thinking about pain, and we include different topics like the biological aspect of the disease, psychological, social aspect. Because pain, the concept is changing all the time. Because in Fabry disease, we used to say it's just the result of neuropathic pain. When you have a damage because of the deposition of CB3 in the peripheral nerves. But there are other type of pain. If you fall in the floor and you have a pain in your shoulder, it's because of inflammation. This is a nociceptive pain. All of us, we have nociceptive pain because of these kind of reasons. But today there are new type of pain, which is what we call the nociplastic pain. In some brains, there is an amplification of the stimulus. So a very low intense stimulus for pain is recognized as a very, very severe pain. And this is explained by the left part of the slide, the psychological. If you have depression, anxiety, you may amplify the pain sensation, okay? And we saw in some of our patients that some patients, they have both mechanisms, neuropathic and nociplastic. The important point is this, the treatment are different. You may need to change the treatment, the symptomatic treatment. So coming back to the different way to treat patients, we have the specific therapies, you know, the classic enzyme replacement therapies, and many other treatments are coming. But then we have the symptomatic treatment, okay? And the symptomatic treatment could be pharmacological. This is what we call the painkiller, the analgesics. You can go to antidiarrheal treatment, of course, but then we have the non-pharmacological approaches. And first of all, if we know the triggers, try to avoid the triggers. If you have pain in hot rooms, try to avoid this. Try to use the air conditioner. Try to keep hydrated because this is super helpful. So if you have a child, a boy, a girl with Fabry disease and the presence of pain is common, try to give a clinical letter and explain this in the kindergarten, in the school. And then let's move to the other non-pharmacological symptomatic therapies. And remember that the physical therapy could be good enough for some patient doing yoga, water therapy. You have different type of this. But then we have the psychological therapies. And this is super important, the biofeedback, the mindfulness. So let me tell you that after me, you're gonna have a very, very interesting talk about how can you coping with this situation, how can you manage this. So stay here because the next one is even better than mine. Let me finalize saying that the same for the gastrointestinal symptoms. Of course, you have to avoid one big meal per day. No. You need several but small meals during the day. And then we have some paper. We are reading that maybe green tea is better than black tea because it has some anti-inflammatory effects, the presence of curcumin in the diet, some supplements, some different things that could be useful. And try to avoid fermentable foods. I mean, try to reduce the formation of gas inside in the intestine. And there are different type of low food map diet. So you can follow this because this is really important, not just this. When you talk about treatment, when you add this change in the diet, this could be super beneficial. So let me finish on time saying that remember that when we say that neuropathic pain and gastrointestinal symptoms are common, it's not just because of that. Because we have to do the diagnosis and we have to keep in mind that this could be enough criteria for a specific treatment. And then when you start on a specific treatment, the monitoring is super important. Because when you do the monitoring, you are looking for some therapeutic goals. And if you cannot reach the therapeutic goals, you may need a change in your treatment. So talk with your physician about this, and thank you very much again for the invitation.
Thank you very much for inviting me to be part of this webinar. I am honored to be here. I'd like to talk to each of you about talking with your physician about your mental well-being. Some of you may have heard me talk about this subject before. I talk about it a lot because it's really, really important, because you are really, really important. First of all, I specialize in health psychology and neuropsychology, which means that I work with people who have medical conditions and I focus on the brain. I've been working with the Emory Lysosomal Storage Disease Center here in Atlanta, Georgia, in the United States for the last 15 years. Prior to that, I worked in large hospitals with hospitalist teams here in Atlanta. These are my disclosures. Where I typically start is with the bidirectional interaction between our physical selves and our psychological selves. And it's really important to pay attention to both of those, that both doctors and patients pay attention to both of these things and address them at each visit that you have with your doctor. Because only by paying attention to both of them can you have good overall health. So the physical self can affect the psychological self. For example, hypothyroidism and stroke can contribute to depression. On the other hand, the psychological self can contribute to how we're feeling physically. For example, for some people, public speaking, like I'm doing now, can make us feel very anxious, and that can result in sweating or jitters in the stomach or sometimes trembling in the hands or in the voice. Last year, Sanofi International invited me to join a similar webinar targeting doctors around the world, physicians, and encouraging them and teaching them how to ask people with Fabry about their stress levels and their mental health or mental well-being at every visit, just like they ask about physical health. After the talk, Sanofi made this incredible slide, and I'm going to use it to share with you what I talked to your physicians about, because I want you to know everything that I told them. We talked about the importance of lifestyle modifications. You can see here healthy diet, physical activity, limit the amount of alcohol you drink, not smoking. We talked about general stress management, practicing relaxation techniques, prioritizing which things are worth stressing about and which things aren't, resisting the urge for perfectionism. We don't have to get every tiny thing right all the time, because we're never going to do that. And building a support network of people that we can rely on when we're not feeling our best. I also talk to your doctors about how to talk to you about your mental well-being. So I asked them at every visit to ask you about your depression, your anxiety, your sleep, your family and social support system, and your current coping mechanisms, and to help you get to someone who specializes in those if that's something that would be helpful to you. I also talk to them about specific tools that they can use to assess for depression and anxiety and even suicidal ideation. I gave them tips on how to talk to you about this, ideally using silence to allow you time to talk, and being caring, really listening to what you have to say. So that's what I talk to your doctors about. This slide is for you, because even after all of that, your doctor may not ask. Maybe they didn't happen to see the webinar that Sanofi made, or maybe they saw it, but they just forget at that particular visit to ask you. Even if they don't ask you, it's very important that you tell them how you're doing, not just physically, but emotionally. Because again, you're important, and this is important to your overall health. So this is another version of the same slide for you as the person living with Fabry disease. And you'll notice that the top part is exactly alike. The lifestyle modifications and the general stress management are the same as the previous slide. What's different is that even if they don't ask you, I want to encourage you once again at every visit to talk to your doctor, to your physician about your anxiety, your stress, how you're sleeping, what level of depression you're feeling, if any, your family and social support system. Mention to your doctor if you experience panic attacks or thoughts of hurting yourself. I cannot stress how important that is. Depression and anxiety are recognized now as something that can occur with Fabry disease at higher risk than the general population. Now, what we don't know is how much of that is Fabry disease itself, an organic symptom, and how much of that is a reaction to living with a rare chronic progressive disease. Or how much is both? For the record, it might be both, but we don't know yet. The good news is that treatment can be helpful. But in order to get treatment, you have to recognize the feeling of depression in the first place and be willing to admit that feeling to someone else, especially your doctor. Psychologists, doctors, other mental health professionals can help. And you can pick your own flavor of counselor for whatever you need. I realize that availability may be different depending on what country you're in, whether you're in a city or a small town, but counselors exist to talk one-on-one or with couples, spouses, families, groups. There are faith-based groups of counseling. There are other kinds of groups of counseling, you name it. it exists. And if you don't feel, this is something I always tell people, if you don't feel like the first person you try is helpful, don't give up. It's very much of a match of what works for you. And not every counselor will work for you. But don't give up. Try another one. Because finding a person that does work for you is invaluable, is priceless, and can have a huge effect on your mental well-being. You don't have to pick someone familiar with Fabry disease. I realize that may be hard to find. But if you can find someone who is familiar with living with chronic diseases in general, that can be helpful. Here in the United States, for counselors working with adults, we're called health psychologists. For counselors working with children, they're called pediatric psychologists. Counseling can involve developing healthy coping skills, reframing perceptions and cognitions, also known as cognitive behavioral therapy, building social support networks, resolving conflict, and sometimes medication can be helpful, although it's not always necessary. Of note, depression can also worsen fatigue, which I know is part of Fabry, and it can worsen insomnia. It is also very, very normal for depression and anxiety levels to go up and down, so you won't feel the same every single day. But it's important to know that both medication and non-medication options do exist. I do want to say, and I do recognize, that some people are more or less open to talking to others about depression for various reasons. Some of those reasons may be cultural. Individuals raised in different cultures may feel more or less of a stigma in talking about and admitting to mental health needs like depression. Some of those influences can be societal. For example, men in many cultures are often reluctant to talk about what they perceive as a weakness, or that they might be in need of someone to talk to. And then there are generational influences. Here in the United States, it is definitely true that those in an older generation may be less likely to talk about depression than those in younger generations. You don't have to use the words depression or anxiety. You can just call it stress if you want to. It's okay to just talk about stress and being overwhelmed, because let's face it, we all get overwhelmed sometimes, and we all experience stress. And it doesn't really matter what you call it. What matters is that you get what you need to help it. All right, so let's talk about rare disease stress, some stress that's more or less specific to rare disease. There's the disease-related stress, which includes all the physical symptoms and the limitations in activity due to your health that you may experience. There's healthcare stress, which may be caused by delays in getting a diagnosis, or the stress of long trips to get an infusion, or uncomfortable treatments if you are not comfortable with needles or anything else involved in treatment. There's financial stress, and I know that insurance differs from country to country. And then, of course, there's the stress of, if you're a woman, you may have been told at some time in the past or even now that you're just a carrier and that you cannot experience symptoms, even when you know that you are experiencing symptoms. And it is well known that women can experience symptoms of Fabry, regardless of what we thought in the past. There's also family stress. Having a rare disease can sometimes be hard on relationships, and again, on families' finances. There's work and school stress, and that can include missing days of both work and school due to your health, and worries about asking for special accommodations, worries about coping with your coworkers or your classmates, especially when they're complaining about small things when you're dealing with much bigger things, or having to go for adults on disability or retirement much, much earlier than you wanted to. And sometimes that comes with feelings of inadequacy or failure. Social stress can include feeling different, feelings of isolation, feeling like nobody understands, missing fun things due to Fabry. All of those rare disease stresses can leave you not feeling quite so good about yourself and about life. Not in everyone, but sometimes. All right, so let's talk for a minute about things that can contribute to depression in Fabry, specifically in Fabry, not just rare disease in general. So obviously there's pain, and that I don't need to tell you, you know better than I do how hard that is to live with and what kind of an effect that can have on you emotionally. Stroke. Sometimes, depending on where in the brain a stroke happens, that can contribute to depression. Menopause, whether it's natural menopause or premature artificially induced menopause due to the removal of your ovaries and uterus, that can absolutely come with depression, although it's not something that's often talked about, but it is true. Insomnia, when we're without sleep, that can leave us fragile and can contribute to depression. Now, of course, depression, anxiety, and insomnia can be side effects of some medications. So it's important to check with your doctor about whether your medications might be contributing. GI symptoms, gastrointestinal symptoms, such as diarrhea, can definitely contribute to quality of life, can interfere with quality of life, and can contribute to depression. And of course, let's not forget life in general, because even people without Fabry disease can have external stressors like divorce or other hard things that can contribute to depression. And then there's the Fabry fog. So many of you may have heard me talk about the Fabry fog before, so we're not going to go through it all today. Just a summary of where we're at now. Researchers in Switzerland did a literature review of all the research that has been done on the Fabry fog so far. Mostly the research was in Australia, Denmark, the Netherlands, Belgium, the United Kingdom. There is a study here in the US that I've done, which is being analyzed. And all of these studies vary from no evidence of Fabry fog to increasing evidence that there is such an entity as the Fabry fog. And I use that term because that's what the people with Fabry told me they called it when I first started working at Emory. Some studies have found that 30% of adults with Fabry disease show cognitive difficulties, usually in executive functioning, which is the frontal lobe here, and is involved in planning, abstract thinking, executive functions. Difficulties in information processing speed, which is how fast you process things, and in attention. Notice that there's no objective evidence yet of memory problems, even though that's something that individuals with Fabry sometimes talk about. What we do know affects memory is depression. So it's even more important to, if you're feeling evidence of cognitive difficulties, to try to treat the depression to remove the effect of that. All right, I like to talk about a four-legged stool. You can see the graphic here. I'm using my fingers as legs as well. This is a stool, and it's pretty stable. And it's got your physical health, your emotional health, your spiritual health, and your social health on it. So when you're thinking about your own well-being and how to tell how you're doing, you want to think about all four legs of the stool, not just, things like depression and anxiety, but how am I doing physically? How am I doing emotionally? How am I doing socially? How am I doing spiritually? And spiritually can encompass a whole wide range of definitions. You can see that the stool with four legs is pretty stable. But if you take away a leg, so if you're not doing so well physically that day, well, now the stool's a little wobblier because it only has three legs. And if you don't have a great support system, a family and friends and doctors, now you're down to two legs. And the stool's probably going to tip over and you're not going to feel so great until you get some of those legs underneath you again. So at any given moment, you have those four legs and you kind of need each of them. It's a way to think about your health. All right, let's talk about coping styles. You want to look at how you cope with stress. And mainly, you want to ask yourself, is what you're doing to cope helping or hurting you? Seeking social support from others with Fabry can be an excellent coping style for many people. Not for everyone, but for many people. Having a drink now and then can help you relax, but having too much to drink, self-medicating yourself with drugs like alcohol, legal or otherwise, is fine in moderation, but can be really harmful if taken too much. So you want to ask yourself and be truthful with yourself about that. And that's true regardless of Fabry. General stress management, some practical tips. There are relaxation techniques. I'm not going to go into them today because I only have 15 minutes, but there are relaxation techniques. Again, learning how to prioritize what's important right now and what can wait till later, and when to delegate, when to ask other people for help, because we don't have to do it all. Again, resisting perfectionism. Intentionally building that support network, both in general and also a support network of other people who have Fabry and know what it's like to live with Fabry. Helping children with Fabry develop their own sense of self-confidence. They're not a sick victim. They're a strong person who happens to have Fabry disease. There's a big difference in those two perspectives. And of course, asking for your help and talking to your doctor. That's the whole point of today's webinar. I like this because sometimes we're the hardest people on ourselves. And this says, of all the people I have had to forgive, I have been the hardest. I have been the hardest person to forgive myself. And that's something that we have to do, especially if we're having a bad day, to not hold ourselves to standards that are not possible to reach. All right, other coping skills include advocacy, being a part of Fabry groups, working to spread awareness of Fabry, finding your passion, whatever makes you feel alive, finding that and carving out some time in your life for that. There are a whole lot of different therapies. One of them is professional therapy, talking to someone. But there's also art therapy, especially when we're talking kids, but even adults. Art therapy, music therapy, nature therapy, pet therapy. That one works for me in particular. And sports therapy is also available, and it's a thing. It's where you take out your stress with physical activity, and it can be a lot of fun too. This one shows axe throwing. I do realize that my time is coming to a close, so I want to just summarize by talking about some mental health boosters. Again, remember there are professional providers, counselors, including individual counseling, marital counseling, family counseling, group, faith-based. There are psychiatrists, those are medical physicians who can prescribe medication if that's something that you would like and that would help. Counseling can involve talking about your coping skills, building social support, reframing cognition, conflict resolution, mediation. Support and advocacy groups for Fabry, again, here in the middle in the green, are really important. There are frequently national Fabry organizations. FIN, the Fabry International Network, who's hosting this webinar, is, of course, one of the main important international Fabry networks. Online groups. Simultaneous infusions is something we do here at Emory with other people with Fabry to build a little local support group, and many other options. And then the coping methods that we talked about a minute ago. All right, thank you for your time and for your attention. And the bottom line is, please, if your doctor doesn't ask you how you're doing, you bring it up to your doctor. You tell them how you're doing in each of those areas so that you can get the most help and the best health possible. Thank you very much.
So don't forget our Fabry Moments curriculum. This is first webinar, Your Monitoring Matters, on October 23rd, 2025, and the second webinar on November 13th, 2025. Timing between 5 and 6 Central European Time. Both days are Thursdays. And please don't forget to scan this QR code to complete our post-event survey, Building Your Care Matters, because it's very important for us for future webinars and to make this even better and fit it to your needs. Thank you very much for your attention.